morning, class.
Morning, sir. Morning.
Good morning,
Are
sir.
you hearing and looking at the PowerPoints? Can you see it?
Yes, sir.
Yes,
Yeah,
sir.
you can see it, right?
Yes, sir.
Okay, let's start then. Today's topic is one of the important topics that we come to the in day-to-day life. That is approach to the polytrauma patient. It is usually the common thing that we need to know because this is commonly seen in emergency as it is an emergency conditions, that is polytrauma patient is in emergency condition. So we need to know the things, what is not to be done and what is not to be done. So better you know about the things before going or approaching the patient with polytrauma.
सर हजुरको माइक म्युट भएको छ
अहिले अहिले ठिक छ
आयो सर
सुनिरहेछौ ठिक छ Are you hearing? सुनिरहेछौ Hello.
Sir. Yes, sir.
Yes, sir. Yes, sir.
Let's continue from objective then again. The concept is the main objective is these concepts, the principles of management of primary and secondary patient assessment, because the primary and secondary assessment of patient results in treatment, and the treatment depends accordingly. So it involves the concept and principle of the primary and secondary patient assessments, and we should establish the priorities in management in trauma situation, because in trauma situation we cannot treat a patient as a whole at that time. So what we need to do is we need to prioritize the thing. Like in case of life-threatening condition, we need to treat airway, breathing, circulation. Then only we can go for the other conditions. So this is the thing that we are learning today regarding this, how the patient approach the patient with the polytrauma. And this is mediated, that is, we initiate primary and secondary management necessary for the emergency management of acute life-threatening condition in timely manner. So that this initiate the primary and secondary management depends upon the primary and secondary assessment of the patient. And this is the whole thing that is involved in this case of management of polytrauma patient. And it is also known as advanced life trauma support, ATLS. Before going to anything, we need to know the incidence. So regarding the incidence, the global injury mortality is 23% is due to the road traffic accident. So the most commonly involving the polytrauma is the road traffic accident. And other things that is involves are war 3%, homicide 11%, suicide 15%, drowning 7%, fire 6%, this falls 8%, and poisoning 6%. So the most important thing is road traffic accidents. So regarding it, road traffic accident being the cause for the polytrauma as the commonest cause of the polytrauma and global injury mortality ratio. Now, there are more than 9 people die every minute from injury or violence. So that this is the scenario that we are seeing in our day-to-day life. So we need to know regarding this approach. 5.8 million people of all age group and economic groups die every year. So this contributes around 5 to 8 million people, and this burden is really significant, such that they're accounting for the 18% of the total world disease. So being it as a 20, around 20% of the cases being this polytrauma patient, so we need to know regarding it. Now, trimodal distribution of the death. This suggests that the people die in 3 stages, such that while they were in early hours, that is immediately people die, that is within half hour of the trauma, patient dies, most of the patient dies in first early hours, so that is immediate deaths. And early hours, that is around 2 to 3 hours, then some certain group of people die, that is early death. And after some time, the death is increased after the period of recovery, that is around 3 to 4 weeks of period, then this is the late death. So what we need to know regarding this is the most of the cases, more than 50% of the cases die in early hours, that is less than 5 hours. So when we can intervene the people regarding the polytrauma within this time period, we can save the patients adequately. So our main focus is to prevent the death that occurs immediately and early death. Because patient cannot come in early hours, that is within immediately, so it may take time. This first hour is most of the cases we cannot treat it. So they almost die. But in early hours, the death can be prevented. So we focus the patient with the early hour death. If possible, this group of patients can also be treated if treated adequately. Now, regarding the history, this there is a orthopedic surgeon, that is James Tanner, who in 1976 had a crash in Alaska, Nebraska, so that there was injury, including him, with his wife and 4 children, and unfortunately, his wife died. But at that time, there was no hospital nearby around, so he tried the primary management that he tried so he could save other his 4 children. So after that, he thought of developing a certain protocol such that it can be applied to any polytrauma and mass casualties. So it can save the many lives as possible as it is. And this ATLS was originated. And this is the man, that is James Tanner, this is the man who developed advanced trauma life support. Now, what is the concept of advanced trauma life support? It is the concept, it is most commonly what we see is treat the greatest threat to the life first, so that first we'll go for the life-threatening conditions and never allow the lack of the definitive diagnosis to impede the application of integrated treatment. Because this panel of treatment that we do in early first hour, it is like some kind of approach that we follow in each and every patient with the polytrauma patient, so that we can save as much life as it is possible. And in this case, a detailed history is not essential to begin the evaluation of patient with acute injury, because history, in history, we can, with the history, we can treat the patient definitively, but this is the approach to save the life, so detailed history is not required as such. Now, initial assessment of the, and this patient includes first the preparation, then trials, then primary surveys, which include ABCDs, with the immediate resuscitation of patient with life-threatening injury, and then with this, there is adjunct of the primary survey and resuscitation. After that, if the patient is outside such that the trauma has occurred in the far area than the hospital area, then we might need to consider the patient for transfer. And if it is needed, we need to do accordingly. And after, if the patient is in this hospital, he or she might need to be referred to the certain department. So we need to do accordingly after that, such that we do the secondary survey. And secondary survey includes head-to-toe evaluation of the patient, and there are also some adjuncts to the survey or secondary survey. And after that, we continue the post-resuscitation monitoring and reevaluation and monitoring. So what happens is, the initial assessment that we should follow is One is preparation, so that we should be prepared while doing anything regarding the polytrauma case, and we should triage it, because triage the condition, that is sorting of the patient so that the patient will get maximum benefit in case of triage. So we triage it, and due to the shortage of the manpower during trauma, so we can allocate the maximum effort to save the patient. So we do the triage so we can treat the patient accordingly and needy people. After that, we'll go for the primary survey. As we say, primary survey, that is ABCDE, that is airway, breathing, circulation, disability, and exposures. This adjuncts to primary survey and resuscitation includes, that is, blood group examination and this arrangement of blood at the same time. What is there? That is, I think there is a background music that is being heard. Please mute or shut it down. Now, preparation of trauma patients occurs in two different clinical settings, that is in the field and in hospital. That, as we discussed earlier, that is in field, what we do is we primarily manage and we try to refer the patient as soon as possible. But in hospital, we need to resuscitate the patient accordingly and treat it definitively. During pre-hospital phase, events are coordinated with the clinicians at receiving the hospital so that the person is informed and the doctors and the hospital staffs are informed so that they are prepared to receive the patient and treat with maximum effort. During the hospital phase, preparations are made to facilitate rapid trauma patient resuscitation. That is, as we discussed, the main primary function of this aim of this ATLS is to facilitate the rapid trauma patient resuscitation, because with resuscitation, there is highest chance of saving the patient. So this is the prime focus that we follow in this ATLS. Now, trials. This is usually done in case of multiple casualties, and multiple casualties are incidents those in which the number of patients and severity of injuries do not exceed the capacity of facility to render the care. This is the scenario such that we see the casualty is usually high, so the facility is less. So in such case, the most important thing is we need to treat the life-threatening problem first, and those with the multi-system injuries, because it is the prime cause for the death. So in mass casualties, what happens in number of patients and severity of does exceed the capability of the staff. So in such case, patient has having the greatest chance of survival and require the least expenditure of time and equipment is managed, and they are sorted such that we can focus on the patients who has a chance to survive. Now, as we proceed of the primary survey, what we do is airway, breathing, circulation, disability, and exposures. At the same time, airway includes the resuscitation associated with the cervical spine monitoring, because this might compromise the neurological state in later on. So we should focus and keep in the mind that we should be able to stabilize the spine at monitoring while monitoring the airway and maintaining the airway. After that, we go for the breathing and ventilation, because after the airway is secured, then breathing and ventilation is important, because without it, there is no chance of oxygenation, so that the patient may land in hypoxia. And they may die accordingly because of hypoxia. And the third thing that we need to discuss or we need to focus is circulation with the hemorrhage control. If there is external hemorrhage, we can keep the pressure and bandage it accordingly until we arrange for the blood. And at the same time, we need to open the wide bore cannula to resuscitate. Other is the disability, that is assessment of neurological status is required for the disability management, so we can prevent the further deterioration of the spinal injury in this case. Exposure and environmental control, this is also required because an exposure, if the patient has exposed to the poison, the thing that he or she is wearing, the clothes may be contaminated. So if we remove it, the contamination duration is lessened such that the concentration becomes less. At the same time, when there is exposure, there might be chance of hypothermia in case of cold region. So we need to be cautious regarding the exposure too. Now, 10-second assessment that is we can do regarding it is ABCD in trauma by patient by identifying themselves, that is Glasgow coma, that can suggest the patient, and asking the patient for his or her name and asking what happened. This states the patient's mental status that we can know for the disability management. Now here, this has been shown that the bag is being shown. There is jaw thrust and chin lift that we see to maintain the airway. So first, assess the airway to ascertain its patency. It is the most important thing. And begin the measures to establish the patient airway while restricting the cervical spine motion, because to prevent the spinal injury later on. Initially, jaw thrust or chin lift maneuver often suffice as an initial intervention. So this is the method. Otherwise, we can go for the Goodwill's airway tube and other measures that we need to do. But if GCS score is 8 or lower, it requires the definitive placement of airway, that is tube, ET tube. And established airway surgically if intubation is contraindicated or cannot be accomplished. So airway surgically, that is cricothyroidectomy, may be the options. So problems regarding it, there might be manifestly trauma and neck trauma and laryngeal trauma, which represents as hoarseness, subcutaneous emphysema, and palpable fracture. So these are things you need to know. After recognizing, we'll look for this externally if there is obstruction, and we'll evaluate it for the Mallampati score, that is a lemon. It is usually known as lemon as a mnemonics. So we look externally, evaluate the patients, and Mallampati scores we'll see for the airway opening such that type 1, 2, 3, and post. This suggests this is absolutely obscure vision, so there is a high risk of difficulty in intubation. Other is obstruction and neck mobility should be checked at the same time. Now, there are 3 types of definitive airways, that is orotracheal through the mouth, nasotracheal through the nose, and surgical airway, that is cricothyroidectomy or tracheostomy. Cricothyroidectomy is through the cricothyroid cartilage, cricoid cartilage, and thyroid cartilage, so that there is a septum, it can be placed with minor injury, and tracheostomy if needed. This is the procedure that has been shown, that is cricothyroidectomy, and 2 procedures, that is surgical cricothyroidectomy with this airway tube or with needle cricothyroidectomy, because it provides a short relief in respiration. Now, breathing and ventilation. Life-threatening injuries, that includes airway obstruction. After that, there may be tracheal lobe injury, or there is tension pneumothorax, open pneumothorax, massive pneumothorax, and cardiac tamponade. It obscures the breathing and ventilation. Or there is simple pneumothorax, maybe the hemothorax or flail chest, such that if the ribs are fractures, more than 2 locations in the same segment, there is flail chest. Or maybe there is injury to the parenchyma, that is pulmonary contagion. Or there is blunt cardiac injuries, because it is the important for pumping, traumatic aortic disruption, traumatic diaphragm injury, and blunt esophageal ruptures. These all leads to the difficulty in breathing, and it is associated with life-threatening conditions. Other significant chest injuries are subcutaneous emphysema, thoracic cross injuries, sternal rib and clavicle fractures, which may complicate the conditions. But these are significant chest injury, but it has not a potentially life-threatening as these injuries. Now, airway problem is if airway obstruction, then laryngeal injury or posterior dislocation of the clavicular head. In tracheal bronchial tree, incomplete expansion of the lungs and continuous air leak after the placement of chest tube suggests a tracheal bronchial injury, and placement of more than one chest tube may be necessary to overcome the significant air leak, such that if the injury is severe, we need to do accordingly. Now, tension pneumothorax. In tension pneumothorax, what happens is air is withdrawn inside, but air cannot leak out, such that it is a one-way bulb. So the tension within the pleural and pericardial, parietal and visceral pleural layer. So the air is entrapped in it, and gradually tension is increased such that it prevents the expansion of the chest. So tension pneumothorax is the immediate life-threatening condition that should be acted immediately. Open pneumothorax, that is a larger pneumothorax, it acts as the airway tract, but it can go through, air can go to and fro through that points, but still there is airway entrapment in the chest because this chest expands through the negative intrathoracic pressures and it cannot be maintained due to this open pneumothorax. Now, how do we manage the open pneumothorax is, like this is shown, we'll cover the this injured side, but we need to open the one side such that it will not land up in tension pneumothorax. Now, massive pneumothorax. This is the conditions in which this pleural space is occupied by the blood, so that hemothorax, and it is if it is more than 1500 ml or 1/3 or more patient's blood volume in the chest capacity, then it is massive. So the massive should be at least more than 1500 ml of blood. Now, what happens with associated with the breathing problem in case of cardiac? That is a cardiac tamponade, that is a collection of blood in pericardial space, can result either from penetrating or blunt injuries, and this results into the decrease in volume containment of blood in this case, so that it cannot pump the more blood. At the same time, the volume gradually compromised and the pumping is defective. So cardiac output is decreased, and this results into the life-threatening conditions with circulation failure. Now this is a picture again showing simple pneumothorax, and this is the picture showing skin, fat, and muscle layer. This is the parietal pleura, and this is the visceral pleura. And what happens in case of pneumothorax is the air is lost in this case of pleural space, and this is the pneumothorax, so that this chest is shrink, and it can be seen in X-ray if we see accordingly. Now, flail chest, that is, if two or more relationships are fractured at two or more places, such that this is fractured here and here, so that it has a in inspiration. What happens is this segment draws inwards, and in expiration, this segment goes upwards. But why it should occur opposite in case of normal patient? So this will result in failure of respiration. Now, traumatic aortic disruption. This is also a common finding that we see in case of polytrauma patient, and it is also one of the sudden cause after vehicle collision or fall from height. So we should suspect further these conditions when we see the trauma and the nature of the trauma, and we should see it in the X-ray. So these are things that we need to do regarding traumatic aortic disruption, because these all are the things that we need to make out in our mind. Now, diaphragmatic rupture is also the conditions. What happens is there is herniation of the bowel into the chest, such that it will compress the chest space. Again, this will have similar symptoms as the respiratory depression. Now, subcutaneous emphysema, thoracic cross injuries, and the fractures of the upper, middle, and lower ribs, according to the numbering that we see, and these may cause contusion with ribs and perfusion of the lung, so exchange is affected. In subcutaneous emphysema, it may increase the dead space so that there is a high chance of respiratory failure. Now, circulation and hemorrhage control. Now, basic principle, what we see is this cardiac output is heart rate into the stroke volume. So there is a preload that is coming into the artery and coming into this heart, that is venous return is a preload, and the cardiac contractility is affected such that it pumps out the blood, and afterload is dependent upon the this arterioles, that is before the capillaries. Just before the capillaries, the pressure is maintained. So afterload defines the pressure, and what happens is if there is a change in stroke volume, there is a high chance of change in heart rate. So cardiac output is tried to maintain accordingly. But if it cannot be maintained, there is a chance of cardiac output failure. So it may be hemorrhagic shock, such that there is a loss of blood. If cardiogenic shocks, in which case the heart cannot pump. In cardiac tamponade, at the same time, heart cannot expand. In tension pneumothorax, at the same time, it will pushes the heart. At the same time, the heart cannot expand. In neurogenic shock, there is pump failure because there is a neurological disruption resulting into the shock. In septic shock, there is a vasodilation resulting into the shock. Now, in hemorrhagic shock, it can be classified into the class 1, 2, 3, and 4. In class 2 is mild, 3 is moderate, and 4 is severe. And in this case, the approximate blood loss that we see is less than 15% in this case, 15% blood volume in this case in class 1, 15 to 30% in class 2, 31 to 40% in class 3, and more than 40% in class 4. And it is around 1500 ml of the blood volume. So what is the protocol is, we need to immediately manage with blood in this case of class 3 and class 4. But in class 2, we can manage with certain procedures like resuscitation with the fluids. And in class 1, we just need to monitor, and at the time, we need to be prepared for the other consequences at the same time. Now, the parameters that is changed in this case of this hemorrhage is heart rate, blood pressure, pulse pressure, respiratory rate, urinary output, classical stoma scales. This suggests there is no change in class 1, but there is some changes in class 2, such that heart rate is normal or increased, but almost all are normal except there is decrease in blood pulse pressure. But in case of moderate, there is increase in heart rate. At the same time, there is decrease in pulse pressure and urinary output, and patient becomes stupor. After that, class 2, there is a high pulse rate. And this is there is a best tip sheet that is more in case of this severe shock. How we treat it? In initial, we administered the warm fluid, body fluids, that is isotonic fluid, that we usually give, that is ring or lactate. The usual dose is 1 liter for the adults, while it is 20 ml per kg for pediatric patient weighing less than 40 kg. And the goal of research is to restore the organ perfusion and tissue oxygenation. So this is the main purpose, to maintain the circulation. So how will you assess these things regarding it, how it is effective or not? Then we'll go for this rapid response, transient response, or minimal or no response. We see for the vital signs, estimated blood loss, need for blood preparation, need for preoperative intervention, and early presence of surgeon. These are the criteria that we need. If there is a rapid response, this the patient, the vital signs returns to normal, and there is estimated to be less blood loss, and there is no blood requirement of blood transfusion is less, but still with type and cross match is done. And need of operation, it may possibly need the operation, whereas the surgeon is always needed to be present at that incident. In transient response, what is happening is the response is transient, such that resurgence of decreased blood pressure and increased heart rate is still seen in this case. So there is moderate to severe in the blood loss, and there might be need of blood in the transient response. So we type specific blood is used, then cross match. We don't do cross match in this case, and we can use type specific blood. If there is minimal or no response, it's indicated to be severe and immediate blood transfusion is required. And emergency blood is done, and O negative blood is transfused. Usually in this case, minimal or no response cases. Now, cross-match specific blood loss that we discussed. Type O blood group, that is O negative, is usually the universal donor that we can give in this case. Auto transfusion, sometimes this is usually indicated in this case is the if the surgery is planned, we give the blood and we store the blood, same portion of blood for some time, usually 2 weeks prior to the surgery, and then we'll give it during the operation, that is auto transfusion. And massive transfusion, what happens is if there is 10 units of packed RBCs is used within 24 hours of admissions, or more than 4 liters in 1 hour, or if it is whole blood is recycled, then it is a massive transfusion. Now we need to see for the abdominal and pelvic trauma. What we do is, as usual, we do inspection, auscultation, percussion, and palpation. At the same time, pelvic assessment is need to be required, because if there is pelvic injury, there is a chance of blood loss. Other is urethral, perineal, rectal, vaginal luteal examination is required, because in urethral injury, if there is bladder injury, there is a chance of urethral blood in the meatus. Now these are the adjuncts. The physical examination that we do is what gastric probe for the prevention of regurgitation, urinary catheter to measure the urine, and fast scan, that is the focus assessment with the sonography for the trauma. So we can see for the bone trauma and chest traumas. Other is DPL diagnostic peritoneal lavage. This is usually done for these invasive procedures, but it is obscured these days. Other is X-ray for the abdominal trauma and compressed tomography. Now, in pelvic trauma, what we need to do is AP compression, so we can see for this open book injury, lateral compression, so that if there is a vertical injury, that is pubic rami fracture in superior and inferior aspect, and in vertical shear, it is a buccal handle injury. This is landing on the ground with the feet, so that the vertical shear is indicated. Now, what we need to do in this case is we need to bind a sheet of towel or pelvic binder or other device that can provide a temporary fixation of unstable pelvis, so that blood loss is prevented. So this is even at the level of trochanter of the femur, and it will help to minimize the blood loss in acutely severe condition. Now, disability. Primary goal of disability is to suspect trauma with brain injury, but to prevent secondary brain injury at the same time, because this can result into the increased disability in later life. So what happens in intracranial places? Elevation of intracranial pressure results into the reducing cerebral perfusion and cause and exacerbate the ischemia. This may land up in the this disability with the immobility at the same time. Normal ICP is usually 10 mm at the resting state, but if the pressure is more than 22 mm, and if it is sustained and refractory, this is associated with the poor outcome with disabilities. Now, Monroe doctrine, this says this is the normal brain, and there is no venous clot outside in the intracranium, and CSF is maintained so that it is maintained. But what happens in compensated stage is this mass, this is either due to this blood, that is subdural hemorrhage, extradural hemorrhage, etc. This results into the compression of the brain mass, but venous return and CSF is, this venous column and CSF is almost normal. But in decompensated, the mass gradually increases, so it will still compromise the blood, such that it will compromise the brain, and CSF will be also compromised. but arterial is minimally compromised. So what the main thing is compromised over here is brain parenchyma. So there is a damage to the brain parenchyma due to pressure. Now, traumatic brain injury, it is categorized into mild, moderate, and severe depending on Glasgow Coma score. If it is 13 to 15, it is mild. If it is 9 to 12, it is moderate, and if it is 3 to 8, it is severe. And morphologically, we should see for the skull fracture and intracranial lesions. In skull fracture, we see the vault and basilar regions. Involved, it may be linear or straight fracture or depressed fractures. But in case, what we see is it is associated with or without CSF because it is dependent upon the region that brain floats on the CSF at this region. So there is a chance of CSF leak. At the same time, the nerve that passes through the basal region that is usually that we see is 7th nerve. So we can see injury with or without 7th cranial nerve. Intracranial lesions, it may be focal or diffuse. In case of focal, it may be epidural, subdural, or intracerebral. In case of diffuse, there may be concussion, multiple contusions, hypoxic ischemic injury, and axonal injury. In axonal injury, we cannot differentiate it as such in this case. Now, in case of Glasgow coma, what we see is eye-opening, verbal response, and best motor response. In this case, if the patient is speaking spontaneously, then we go for score 4. Otherwise, if we ask and he speaks, that is to speak, then it is 3. And to pain, then it is 2. If it is non, then 1. But it is revised such that there is non-testable. Sometimes we cannot test it. It is as non-testable. In verbal response, if the patient is talking orientedly, then we give the score 5. If it is confused conversation with blabbering, we use for the score 4. Inappropriate words, so that the condition, the situation doesn't define, then it is 3. And sometimes patient is unable to speak with the incomprehensible sound, then we'll go for the score 2. And if there is no sound, then 1. In best motor response that we see is patient is asked to mobilize the limbs, then he or she obeys the command, it is 6. If he or she can localize the pain, then it is 5. If the patient withdraw to the pain such that patient has the tendency to show the protective response, then it is 4. If it is abnormal flexion, then it is decorticate posture, then it is 3. And in extension, the patient extends its body, cerebral posture, then it is 2. And if there is no response, then it is 1. Now, this is the epidural hematoma, and this is subdural hematoma. This is the epidural hematoma, that is, so it has a convex architecture that can be shown. It is epidural hematoma, or there is subdural hematoma is shown, and basilar contusions that we see. And the parenchymal hemorrhage that we see, it pushes the parenchyma to the opposite side. Now, what is the initial management of this traumatic patient? Initial management is we need to take the history and neurological examinations, and particularly we should ask for the anticoagulants because there is a chance of bleeding disorders which is associated with it, and patient might be using anticoagulants. At the same time, it provokes an increase the blood loss in this case, so we need to know the history. And what we do is patient may be discharged if these criteria may not be met. But if there is certain conditions like indications below, we need to admit it, like no CT is available, CT abnormal skull fracture, CSF leak. If there is focal neurological disease and GCS does not return to 15 within 2 hours, they need to admit it. But if the patient is normal and we are able to have CT, it is suggestive with normal, we can discharge. But still, we should be cautious and patients should be asked accordingly. In moderate, what happens is neurosurgical evaluation is required, and this is usually done after the primary and survey and resuscitation, and we arrange the transfer the definite neurosurgical evaluation and further management. So this is done by neurosurgery, and if there is severe, that patient is dying, first primary resuscitation, and then we need the urgent neurosurgical consultation. this traumatic brain injury, the most important thing that we need to do is the CT, because CT scan helps in finding the diagnosis and helps to treat accordingly. So these are the criteria with what we need to know regarding the indication for CT for the high-risk neurological intervention. If TCS is less than 15 within 2 hours after the injury, we need to do the CT. If we suspect depressed fracture, we need to do CT, vascular or hemotympanum, trachonine, CSF, otorrhea or rhinorrhea with the battle sign. We need to do the CTs. And if there is vomiting, and if the patient is 65, and if the patient is using anticoagulant, then we need to do the CT. Otherwise, in case of moderate risks for the brain, such that there is loss of consciousness for more than 5 minutes, amnesia after before impact, and there is a dangerous mechanism such as pediatrician struck by motor vehicles, this might be needed the CT. Now, what we need to do in case of brain injury is to prevent the hypovolemia. We need to be careful. So the hypovolemia is the most common treatment that we need to do in case of brain injury. At the same time, coagulation therapy or ventricle correction is needed because there is a chance of bleeding in case of brain, and if it is not controlled, there is compromise of the brain. And sometimes it needs hyperventilations by reducing the PCO2 and causing the cerebral vasoconstriction so that it helps to prevent the ETV. And other is mannitol, that is 20% solution is used, and it decreases the intracranial pressures. So the main mechanism or the principle is to prevent the secondary brain injury. Now, this is the thing that we need to do. That is a spine board, that it has a strap from head to toe, that is support for the head at the same time with the restriction of movement of the cervical spine. And chest strap, body strap, and leg strap so that it is immobile. Now, we need to see for this spine and spinal cord trauma because later on, the patient may land up in the paralysis and neuropraxia that might be seen if it is treated correctly. Neuropraxia can be overcome, but in paralysis, it is difficult to overcome. This is the anatomy that is known. What we need to know regarding this is the brachial plexus and lumbosacral plexus that we need to know. In brachial plexus, what we see is C5, that is area of deltoid. We look for the biceps, and C6, this is wrist extensors. In C7, we'll ask for the triceps, that is elbow extensors. These are the sensory regions, and these are the motor regions. In C8, we'll see for the finger flexors, and T1 with the finger abductors. For L2, what we see is hip flexors, flexion of hip, and in L3, knee extensions. In ankle dorsiflexion, it is L4. In L5 is toe extensions, and S1 is the plantar flexor rest bones. And these are the sensory regions that we need to. Now, neurogenic shock versus spinal shock. Neurogenic shock results from vasomotor tone and sympathetic loss of vasomotor tone and sympathetic innervation to the heart. Injury to the cervical and apothoracic cord cause impairment of descending sympathetic tone, and spinal shock is referred to flaccidity or the muscle tone and loss of reflex that is usually result from spinal cord injury. Is the spinal cord, and neurogenic is usually the sympathetic innervation, so that the injury is above the cervical or thoracic region, that is T6. Now, management is restricting spinal motion to prevent the further injury, intravenous fluid to maintain the blood volume, medications sometimes needed if it is the inotropics, and transfer if appropriate that we do. Now, this is the topic that we should not neglect, that is musculoskeletal trauma. And this is the showing tibia injury, that is Gospel-Anderson type 3C injury might be because there is an injury to the, it seems injury to the vessels. So it might be type C injury, likely, at least type 3B. This is usually delayed until it is a life-threatening injury. If it is a life-threatening injury, what we do is we pack the limb with a bandage and we try to apply the tourniquet if needed to prevent the further blood loss. Initial assessment is usually identified For the injury of the lacerating injury, then after we'll go for if there is injuries that pose a threat of life or limb, then we'll act accordingly after that. Although uncommon, lacerating must be prone to assess and manage. It is a stage approach, so this control utilizing the applied direct pressure, strain, and tourniquets as we discussed earlier. Most extremity injuries as appropriately diagnosed and managed during the secondary survey. So this is usually done in secondary survey, and we'll go for the proper management, that is external fixation in such cases. But the only prior thing that we need to do regarding it at a certain moment, that is initial phase, is apply the splint, restrict the motion, and prevent the further damage. That is, prevent further blood loss. Either maybe the tourniquet or maybe the compression bandages that may be required to prevent the loss of life. It is essential to visualize and manage artery injuries because it might result in compartment syndrome, as discussed, open fracture, cross injury may land up in this metabolic syndrome, and other is dislocations in the timely manner because these needs urgent emergency treatment. And the things that we need to focus is pediatric trauma to be taken cautiously, at the same time geriatric trauma and those with the pregnancy and immediate partner violence is required. So this concludes the ATLS, and this is the approach that we should follow, that is A, B, C, D, E, that we follow in case of polytrauma patients. So this concludes the topic. Thank you for the class, for attending. Have a good day.
Thank you, sir.
Thank you, sir. Thank you, sir.
Happy birthday, Abhijit.
Happy birthday, brother.
Happy birthday, Abhijit.
Happy birthday, Abhijit.